The knee joint is made up of 3 compartments that help spread load and maintain smooth, frictionless motion. There's one inner or medial compartment, one outer or lateral compartment, and one patellofemoral or kneecap compartment. They're all connected as one joint by a continuous capsule that surrounds them and keeps the joint fluid flowing around all of the ends of the articular cartilage. The menisci of the knee are 2 horseshoe-shaped washers that help the round bones of the thigh or the femur fit snugly onto the flat bone of the shin or tibia, and this is what we know as the knee. Like most soft tissues, the menisci are made up of collagen fibres that form a special kind of hybrid tissue called fibrocartilage. It's smooth and glossy like cartilage that lines our joints, but with more thickness to resist compressive impact forces and more flexibility so it can resist stretching or tensile forces. So I'll now explain the concept of hoop stress. The menisci have a very unique architecture of collagen that allow them to resist rotational forces and to absorb vertical forces by acting like a rubbery hoop. In effect, the meniscus creates stability and protects the underlying cartilage that lines the bones. And even partial meniscectomy, where we cut out a little bit of the meniscus, increases the risk of osteoarthritis by about 5-fold. So it's critical to try to preserve your meniscus if it is at all functioning. The blood supply of the meniscus is very important to understand because it comes from the outside in. This means meniscal tears in the outer third of the meniscus have the best chance of healing, while tears along the inner rim have a poor chance. This has critical importance to whether a meniscus tear is appropriate for suture repair in the case of a good blood supply, or partial meniscectomy or debridement in the case of a poor blood supply. Acute meniscal tears can occur in younger patients with compression and rotation mechanisms, but they're unusual in isolation. Many of these occur with other ligament injuries. We much more commonly see chronic meniscal tears, which are more appropriately termed wear than tear, and they occur with aging. They're usually part of the spectrum of osteoarthritis of the knee, and surgery for these has been shown to be unhelpful in most cases. Patients will generally have pain that localizes to the side of their meniscal area and joint line. They'll have swelling of the joint and they'll have pain with any loading and particularly with twisting movements. Whether acute or chronic, if patients are having trouble and mechanical symptoms including locking or painful clicking, giving way of the knee, a surgical opinion should be obtained. Types of meniscal tear. There are a variety of different patterns of meniscal tears. Peripheral tears occur toward the areas with more blood supply, and when they're painful or unstable, a surgical opinion should be obtained. Tears can progress and become unstable. Bucket handle tears, where a section flips toward the middle part of the joint, can be very painful. And radial tears involve the margin of the meniscus, which has a poor blood supply, while a parrot beak tear is really just an extension of this kind of tear. Complex tears are combinations of tear orientations, usually affecting the inner margins of the meniscus. Finally, horizontal or degenerative tears tend to be along the plane of the meniscus, and they're often associated with perimeniscal cysts, where fluid is pumped in a valve-like mechanism from the inside of the joint to the outside. Treatment options. The first-line treatment for stable meniscal tears that aren't displaced or causing locking of the knee is a non-surgical approach, including relative rest, optimal loading, and sometimes anti-inflammatory treatments. When the pain and swelling are impeding the capacity to perform even basic strength exercises, a course of oral anti-inflammatories or the use of injection adjuncts can be very effective to settle pain and create an opportunity for the redevelopment of strength. If cortisone is used, It should be used sparingly because multiple injections in short succession have been shown to accelerate cartilage loss. Biomechanical assessment and awareness of aggravating movements is very helpful to maximise recovery, particularly where there are alignment issues. After a minimum 8-week period of this approach, a surgical opinion is warranted if the patient still has significant pain. This is because there have been multiple consistent studies published in the modern era that show there's no overall difference between sham surgery or meniscal debridement surgery in patients with stable meniscal tears. It's now the standard of care to recommend a non-operative approach in the first instance for stable meniscal tears. Of course, while it's a useful guide, this can only tell us about the average and not the individual response to surgery, so this always needs to be an individual decision.
I hope you found this video useful. I create these educational videos to help empower patients by allowing them to understand their problem, treatment options, and the expected recovery. Please remember, this lecture is for educational purposes only, does not constitute the giving of medical advice, and no patient-doctor relationship is formed.